My name is Dr. Luis Raez. I am the medical director at Memorial Cancer Institute, that is part of Memorial Healthcare System in South Florida. And I also professor at Florida International University. I'm going to talk briefly about immunotherapy for patients with driver mutations. After many decades doing chemotherapy for lung cancer, it was very exciting for us to discover driving mutations, these oncogenes that are responsible for the generation of the tumor. And now that we have several drugs available to target these genes, we call this target therapy, we are very excited that we are using all of these drugs at least in 20% of the population in the United States, and all of these patients are not going to have chemotherapy from the beginning, or maybe never. And now also we got a second wave of discoveries with the implementation of immunotherapy for lung cancer. We have 3 agents already approved in America, and there are several indications, first line, second line, and there are more agents and indications coming. So it makes sense, or is logical, that if the patient, for example, has target therapy, he believes that after he fails target therapy, he should get immunotherapy. But unfortunately, it's not like that. After the patient has enjoyed this option to be safe from chemo for the beginning of his treatment, he has to go to chemotherapy before immunotherapy. The few studies that we have of patients with target therapy going straight for immunotherapy show that the outcomes are inferior than the patients don't have any mutation. So in other words, patients with actionable mutations, patients with genetic aberrations, do not respond very well to immunotherapy like the other patients. Why is that? There is a lot of controversies to try to understand what is happening, but also makes sense because we also have discovered that, for example, patients that are older or patients that smoke more cigarettes may have a better chance to do better with immunotherapy to patients that are non-smokers. And the non-smokers are the patients that have the genetic aberrations. And the patients that are older and smoker, they have less chance of genetic aberrations. So in other words, apparently, I don't want to say as a conclusion that they exclude each other, but I only can tell you that makes patients that are with adenocarcinomas, do not smoke, or are former smokers, we have a high chance to find a genetic aberration, while the patients that are older, males, smokers, we have a lower chance of finding genetic aberrations, but a higher chance to respond to immunotherapy. This is very important because, as I said before, all of us are excited with the new drugs. Everybody wants to get the new drugs, but it's not in the best patient. It's not in the best interest of the patient to skip these steps. So first is target therapy, second is chemotherapy, third is going to be immunotherapy for these patients. This is for now, until we can get more information, and maybe the standard may change.